nice to be here and be able to talk to you folks about this subject. So I grew up in Pennsylvania, and I went to undergraduate at Bucknell University in Central PA, and then I came to Long Island for medical school, and then I continued my training here on Long Island for 3 years at New York Presbyterian Health System. And then during that time, I knew I wanted to become a surgical oncologist, and I was advised to go ahead and find some research opportunities for myself. And I found myself at the National Cancer Institute, where I did 2 years of basic and translational research. And that really shaped my career in learning how to ask questions and try and come up with answers for very complex problems for people with cancer. Then from there, I was taken back to New Jersey and finished my training at Rutgers Robert Wood Johnson Medical School. And then I went to The Ohio State University at the James Cancer Center to complete my training in complex general surgical oncology. And it was really at Ohio State and during my last 2 years of residency that I really became passionate about treating patients with peritoneal surface malignancies with cytoreductive surgery and HIPEC. So there's a lot of questions around cytoreductive surgery and HIPEC, and in some communities, some feel that this is still an experimental treatment and that results are kind of waxing and waning between different patient subtypes. But I feel like this is the standard of care, and we really need to progress the field forward. Basically, what cytoreductive surgery is, it's the removal of all the visible tumor in the abdomen that we see. So some patients with cancers that come from the gastrointestinal tract, or even some outside the gastrointestinal tract, they have cancers that spread to the lining of the abdominal wall, to the surface of the organs within the abdomen. Or they have tumors that start primarily on that surface. Like you might hear of people with mesothelioma. A lot of times you think of mesothelioma, you think of commercials on TV with, like if you've been exposed to asbestos, you might want to call because you have mesothelioma in your chest. But you can also get it within the abdominal cavity. And that the primary treatment for that is cytoreductive surgery and HIPEC with or without chemotherapy through the IV. But in a lot of patients, that if we can believe that we can get a complete cytoreduction, so remove all the visible tumor from the abdomen and use intraperitoneal chemotherapy to try and get the tumor cells that we know that are there but we can't see, we feel like we can give patients meaningful long-term survival more than standard therapy with chemo through the IV can offer to people. So HIPEC is done in the operating room. So HIPEC stands for heated intraperitoneal chemotherapy. And most of the time, but not all of the time, that is done in conjuncture with cytoreductive surgery. So for example, if you have a patient or you are a patient with, unfortunately, to have colon cancer, appendiceal cancer, ovarian cancer, even sometimes gastric cancer that has spread to the lining of the abdominal wall, most of the time what we do is it's a two-step approach, and it's the same operations. We'll remove all the visible tumor from the abdomen, and then that is followed by heated intraperitoneal chemotherapy, where we use a perfusion machine and we're able to circulate the chemotherapy in fluid throughout the abdominal cavity. And the thought is that this can get the tumor cells that we can't see or remove, and that we heat it up to help with the penetration of the chemotherapy into the tumor, and even might help the chemotherapy work a little better. There are some very select circumstances where we do this in a what we call a neoadjuvant approach, or where we do it before we go ahead and do cytoreduction. And those are in very select individuals with very certain cancers and biology that they've exhibited that they might benefit from this type of therapy. So that's a long way of saying that, yes, most of the time this is done in conjunction with surgery in the operating room. There are some studies of people getting indwelling catheters. So if you look online, you might see that treatment, and what that is basically a port that goes into the abdominal cavity where they can give chemotherapy through that. But that is more of currently under investigation. So yes, most of the time it is given at the same time as surgery. That's a difficult question because it's all really how much disease you have to start with. Because what we need to do in order for you to be a true candidate for cytoreductive surgery in HIPEC for colon cancer, it basically is from where you start from. So in order to get you to NED, it basically is at a starting point, and that's kind of where the preoperative workup comes in and all the steps leading up to going for the completion of the cytoreduction and the HIPEC. Is a lot of times you get a series of scans, you may or may not get chemotherapy beforehand. And most of the time with all of my patients, I do a diagnostic laparoscopy or put a camera inside the belly to pretty much assess to see if you are a candidate for that. But I would say it's probably on the range of about 30% of individuals that we find can proceed to cytoreduction and HIPEC, because there's certain things we look out for and certain organs that we can't completely remove from the body, which are stopping points, which we like to know before we go ahead and do a major abdominal surgery. So some of those things would be if all the small bowel is involved, where we can't take it all out, if we don't think that we can clear all the disease up and around the liver, where like the portal vein, the bile duct, the hepatic artery goes in. That's very hard and you can't clear all that. Generally not a candidate to get the surgery and move on. If there's a indication we might need to remove your entire stomach, that'll be a stopping point, because we know people just generally don't thrive well after surgery when you need a total gastrectomy or your entire stomach removed in conjunction with the rest of the cytoreductive surgery and HIPEC. So in order to render you NED, there's a lot of decisions and a lot of steps to go along the way. And then we use the HIPEC in an attempt to try and keep you NED afterwards. So that's a really good question. So there are some studies looking at prehab before operations, not just cytoreductive surgery and HIPEC, but major abdominal operations. So I always tell my patients, eat as much as you can, high protein. I really try and get them to get protein supplementation. I think that's all very important, because a lot of patients with this problem, they lose a lot of weight. They kind of struggle to keep that on. And I also think it's very important to be active, to get up and walk around as much as you can during the day, get your exercise tolerance up. So when it comes to the time of surgery, that you're fit and ready to go, and that you can have the best outcome that you can have. I love that this is being asked, because I think it's a very important thing. And I tell my patients all the time, you can't be couch potatoes. You got to get up, you got to walk around, you got to stay physically active, and you got to eat. I think the main thing is that you need to get the nutrition up, because like I said, that a lot of patients afterwards, they can have a tube in their nose until they prove that their bowels are working and that everything's recovered. So I like to get that nutrition as good as we can get it before surgery, because that'll help you heal, and that'll really help things go better after surgery, in my opinion. I generally tell my patients to expect to stay in the hospital about 7 to 14 days afterwards. For my patients, I keep a nasogastric tube in, or a tube down the nose into the stomach, until you kind of prove that your bowels have waken up. Because during surgery, you can have a resection of your small intestine or a resection of your large intestine, and the chemo perfusion of itself can kind of make the bowels stop working a little bit, and you get what's called an ileus afterwards. So it's very important to understand that you're going to be in the hospital for roughly 10 days is on average, but 7 to 14 days is kind of where we can expect you to be. We need to keep your pain under control. These are done under generally a large midline incision. So it's very important that your pain is well controlled, so you can get up out of bed and post-op day 1. Want you up and walking around. Want you to be able to take deep breaths. Don't want you splinting. Don't want you to get pneumonias. And it's all about kind of just trying to make little steps every day to kind of try and get out of the hospital. The most common chemotherapy I use is mitomycin C. Most of my patients that I do this for have either have colorectal metastasis or appendiceal metastasis. And generally in the United States, most surgeons use mitomycin C for this. This can cause some what we call myelosuppression, or decreased ability for your bone marrow to make blood cells. So we do keep an eye on that afterwards. But the theory behind giving the chemo intraperitoneally is to have minimal spillover as possible into the bloodstream or systemic circulation. But it does happen. So you can have some systemic toxicity from it. Another common chemotherapy that we use is cisplatin, and sometimes the OBGYN surgeons use that a lot. And that can cause some issues with kidney function afterwards. So we do keep an eye on that after surgery. Here at NYU Langone, we're part of the Perlmutter Cancer Center. So you really have experts from all walks of life all over the world treating you for your peritoneal disease, and to come up and design not just a HIPEC program, but a peritoneal surface malignancy program to treat these patients where they get the best multimodal care that they can get, meaning they have experts from not only surgery, but they have experts from medical oncology, radiation oncology if we need it, as well as support from specialists in nutrition, social workers, everything that we need to get you up to surgery, but also help your recovery afterwards, and to look into the future on what life will look like after surgery as well. We can do remote consultations for patients. You have to just call my office and we'll set up a remote appointment for you to talk. Sometimes it is a struggle, and I understand that, to get here physically in person, but I think part of the stepwise process of going to surgery is to actually meet each other face to face. So I think an initial consultation remotely will work, but then I think it is helpful to see each other and get a gauge of if you will tolerate this operation. Generally not. So not all chemotherapy causes hair loss. So a lot of people think, if I'm going to get chemo, I'm going to lose my hair. But not all chemotherapy causes you to lose hair. So generally after HIPEC, you do not lose your hair. So some chemotherapies can cause you to lose hair if you do have systemic chemotherapies. I have not come across a big issue with the intraperitoneal chemo losing hair. Generally, this is done one time. So you generally don't lose your hair, but there are support groups. There are people you can go through a cancer center that can do support as you're losing hair, to do cooling therapy or something to help you stimulate hair growth or help you recover after that. So there are resources to look through, and I would reach out to cancer center to see what resources are available, because they are there. Gastric cancer is one of the tougher, more resistant cancers that we treat with HIPEC. I think anytime you're going to treat somebody with cytoreductive surgery and HIPEC, the number one thing that you need to take into account is their disease biology. And what I mean by that is how their disease is presenting, how aggressive the disease is, and what the outcomes look like after we would do cytoreductive surgery and HIPEC. Because what I don't want to do is take you to the operating room for an operation that is not going to be of any benefit. So gastric cancer is one of those cancers that we need to be very selective on people of who we do this operation for. Meaning, if we do it and we believe we get complete cytoreduction, we think all the tumor's gone, we perfuse the chemotherapy, it still can come back, and it can come back rather quickly, and it can come back rather aggressively. So what I think the best approach into treating patients with gastric cancer is to be very selective. Patients that have a low burden of disease and people that tend to respond to systemic chemotherapy are probably the best candidates for cytoreductive surgery and HIPEC. And gastric cancer still kind of needs a long way to go with clinical trials and studies to really find the best patients, the best biological markers to select the people that would do the best and really have a good outcome after surgery. So you can have drainage from your wound up to about a month. It all depends on the size of your wound, how much tissue you have between the skin and the abdominal wall. Sometimes you get what we call fat necrosis, or that the tissue, the fat in between the skin and the abdominal wall dies from when they suture it up. But I would see your surgeon if you continue to leak after a while, because that could mean that you might have a small hole in the fascia, or like the layer of your abdomen. You might be leaking some fluid out of there. Most of the time that scars up and heals on its own after a couple weeks. So I think HIPEC and cytoreductive surgery is a great approach to select patients. I think what we need to do is to further investigate what patients are really true candidates for it. But I think that if you want meaningful long-term survival, meaning in some patients up to 40 months after diffuse metastatic disease, I think cytoreductive surgery and HIPEC is the way to go. And I think the best thing to do is get a really good multidisciplinary approach for your disease, and go to an expert center where people do it all the time. I think that's the best way that you have the best outcomes.